All right, welcome to the scan along for the foot and ankle region. We're going to start in the foot and ankle and the anterior ankle. For this, I like to kind of have the ankle on the edge of the table, kind of hanging off, so I can kind of move it around a little bit. But you could have them with their knee bent, resting on the table. Again, it's a little bit down to patient comfort for your positioning. But from this position with just the ankle just resting off the table, I'm going to take my probe, and the first thing we're going to look for is the talocrural joint. And so we're going to take our probe, put it right at kind of like the ankle crease, just underneath the malleolus. And from here, we're going to look to identify the talar dome and the tibia. And so that's the talocrural joint. If you can't find it, I'd recommend that you take the probe and move up the tibia so you can know you're on the tibia, and then just slide down until it drops off here. And what we're looking for is this structure right here is the talar dome right here. And this is just articular cartilage here, this kind of anechoic line here. And so we're looking for, to make sure this is some joint capsule, connective tissue, and we want to make sure there's no fluid in here. This is where we're looking for anechoic fluid to kind of fill this space, see if there's any joint effusions here. If you slide down from the talar dome, it always looks like just like any kind of tarsal or metacarpal carpal bone or tarsal bone. They all look very irregular. And so the neck of the talus is here, and it has this very unusual kind of appearance, so don't get too distracted with that. But right here we want to look at very important to look at the talocrural joint, and you can move the probe both more laterally and look at the lateral edge, and move more medially too, and look at the entire joint. Then you're going to take your probe and move your probe just 90 degrees to look at, if we're right here, we're going to look at the talar dome in short axis, and we're looking at the cartilage here, and this is again where we're looking for some effusions. We want to come all the way lateral here, and you can move the probe up till you run into the tibia, but you really want to try to image all of this. Now, while we're here in short axis, we're also going to take a moment and look at all the anterior tendons, and that includes your tibialis anterior, your extensor digitorum longus, and extensor hallucis longus as well. And so, if we're starting from medial, we can identify, these tibialis anterior and digitorum and hallucis over here, and you can move your probe to just identify all of these structures as they go down. There's the tibialis anterior moving down, so you can slide your probe up and down and watch them turn into muscle and tendon. And we're just making sure, so there's one, here's two, and we move over again. There's a third one over here. That's the digitorum, where we can actually see it kind of splay out and eventually become all of the extensor tendons. So once we've kind of identified those, you can take your probe and also look at it in both short and long axis, just to take your probe and move it 90 degrees so you're along there, and we're looking at that nice fibrillar pattern of these tendons. Each one of them you can move over and look at each one of them. If you identify this kind of anechoic structure right here in the middle, that's just a vessel right there. You can compress it to make sure, but that's very normal vessel to identify as it becomes your dorsalis pedis there. So those are the main structures of the anterior ankle. Then we're going to start looking at some ligaments. And the first one we're going to look for is the anterior inferior tibiofibular ligament, which is a ligament we're worried about with high ankle sprains, and that goes from the tibia and to the fibula. Now, when you look at the ankle, it's important to know your anatomy. This ligamentous structure actually goes from the fibula, it kind of goes up almost cephalad as it attaches to the tibia. So our probe is actually going to end up being at this angle. But the way we find it, I like to kind of cheat a little bit, and if we come back to that talar dome, it kind of looks like a flat smile. Again, we could start from the talocrural joint, that first image, and turn the probe 90 degrees and try to find the talar dome here. And if you slide the probe laterally, kind of looks like the lateral edge of the talar dome has this little hilltop. And we move from there, slide up, and we could see two bones up here and here. We're gonna do that again. Here is the talar dome, and we see these two bones. And to the left here is the fibula, and to the right is the tibia. Once you find and identify those two bones, then we can start to look for the ligamentous structures. And you can see my probe is going to turn a little bit here so I can get a little bit more in line with those ligament structures. So I'm pointing just a little bit cephalad, but not much. And so once we've identified this ligament, you can actually stress it. Now, again, if they're hanging off the table, hopefully their knee's a little bit bent, but what you're going to do is take the ankle, put it in dorsiflexion here. And as you put it in dorsiflexion, then you're going to externally rotate, and you can see that ligament kind of right here go from kind of relaxed. You can see it gets a little taut as I just go in a little external rotation. Now, the right way to do this stress test is to have the knee flex, so you can take the the gastrocs kind of out of this, and just so you can really externally rotate them and dorsiflex them a little bit more. But I feel with the ultrasound, just a little bit of dorsiflexion, external rotation, you can get all the information you need to make sure that ligamentous structure right there is intact. So once you've identified that one, and we're looking for high ankle sprains, the next thing we're going to look at is slightly more challenging, and it's the ATFL, or anterior talofibular ligament. So that one, we're going to take our probe and keep it on the fibula here, and we're just going to pivot this part until it comes down. We run into the talar dome again, and so here we're at the talar dome, and this is articular cartilage, so there's no ligament that's going to attach there. We need to keep moving down the talus until it flattens out, and once it starts to flatten out, then we're looking for, I'm going to switch hands here. I'm going to do that again. We're going to look for, again, right here, talar dome. We're going to move the probe until it flattens out. And once it's flattened out, now we might need to move the probe, just slide a little bit inferiorly. And this is the ATFL going from fibula to talus here. And you can see it's distinct from the rest of the connective tissue. It moves from fibula to talus here. I'm going to do that again. So again, here we are at the ATIFL. We're going to slide off the tibia onto the talus right there, and we'll keep rotating our probe until it flattens out. And if you see my probe, I'm kind of pointed down the ankle a little bit, and that's where that ATFL is. If you want to stress this, I like to do kind of an anterior drawer just with my other hand. And so my other hand here, my thumb will be on the tibia, and my fingers here on the calcaneus, and I'm going to just do a little bit of a stress like this, like an anterior drawer stress test. And that's usually just enough to really kind of produce any kind of unusual gapping or stress that ligament and for its integrity right there. You could also put them on the table with the knee bent and just do a reverse anterior drawer, which you just push on the tibia as well. But I feel like this gets the information I need as well. So there's the ATFL. Now, a nice thing you can do with the ATFL once you get a good handle on this is you can turn your probe into short axis, and that's a good way to determine if there's any kind of major tears. So you just take your probe, turn it 90 degrees, and so you should make sure you're on the ATFL first, and then as you turn it 90 degrees, right here kind of has this little pocket that the ATFL goes to and attaches right here on the fibula. So here's the fibula moving distal. It's going to be this connective tissue bundle right here attaching down onto the talus. It can be tricky in short axis, but it's a good way to determine if it's torn or how much of it is involved. Once you can look at it in long and short axis. I like to do that as well. Okay, before we look at the CFL, we're going to look at the fibularis or peroneal tendons, both longus and brevis. And the reason why we're going to look at those first is because the CFL goes right underneath them and kind of acts as a hammock. So if we've already identified them, that's a good thing just kind of look for first. So right behind the medial malleolus, we're just going to put our probe right down on top. And here we should see longus and brevis here. The way I always know which one's brevis is because brevis turns into a muscle later than longus. And so down here you see there's more muscle tissue still as brevis is turning into a tendon here. But these are right behind the medial malleolus. If someone has some, clicking or popping, you might be able to have them move their ankle in like a circle, and you kind of see them if they've. There you can see some tendon. There you go. See them flipping around. It might pop around each other as they do that, and that's usually what that clicking or popping is here. But here we're looking at these two tendons, and then we can also look at them in long axis here as well. And so these are these two tendons, longus and brevis here, and you can follow each one of them down. Now, while I don't track the longus all the way down, I always do track the brevis and look at it how it attaches to the fifth metatarsal. And so here's the fifth metatarsal. You can just take your probe and put it right on top of that bone, and then from here you want to make sure you can identify kind of the attachment of the brevis right here on top, right to the bone, right there. So there's the fibularis brevis, and then you want to image the fifth metatarsal, just because this is where common pathologies, avulsions, Jones fractures can occur. So you want to make sure you can scan that structure, and you can do it in short axis as well. Short axis, and then long axis as well. Okay. After you've done that, then looking at the CFL, I will tell you, teaching this is probably the most difficult structure to image in the foot and ankle region. That's at least a common structure we look at. And it's important to know the CFL. So we look at our fibularis, longus, and brevis that come right behind the medial or lateral malleolus. The CFL kind of goes usually a little bit posterior to the calcaneus. It's not straight down. It's a little bit more posterior from the fibula. And so we're going to take our probe and put it directly down in that angle. And there's a couple ways to look for this structure. So right here, we can see the two fibularis tendons here, and we're looking for it underneath, deep underneath. And so you can see, we can't see, we're going to have to move our probe around quite a bit. We may have to turn it a little bit. If you're really having a hard time, you can move further down onto the calcaneus, and then you can start seeing that structure here. And you can see it here to here. And so it's pretty tough to identify. I'll change my depth a little bit. So here we can start to see that ligamentous structure down here, deep underneath there, going from all the way down in the calcaneus here. And then if we move up, you kind of lose it as it's making its way up to the fibula here. And so it's here, and you lose it. It's the anisotropy, and it's tucking behind these two tendons, so it's not being friendly. There's two different ways to really stress this and look at it. One is what we call the Taylor tilt test, which is to make sure you're taking the calcaneus and not the mid or forefoot, and move the calcaneus into inversion. And as you do that, I just want to have your eyes right here. It acts as a hammock and pulls the two fibularis tendons that are up here. It pulls it up. So as you're doing this, it should just see how it kind of moves up. Do that a couple of times. Sometimes, but in my experience, like, there's a lot of patients, especially acute ankle sprains, that don't tolerate that movement very well, and they won't like it when you do that to their ankle. So the other thing you can do is just take the ankle and put it into maximum dorsiflexion. And so as you do that, you can see similarly, it comes in a much clearer view there, right here. You can see we're having a hard time getting it all the way to the calc, but this is it right here, the CFL, right underneath, like a hammock, underneath these two fibularis tendons, right there. But again, you can see it move all the way from down and kind of lifts it up like a hammock. So if it's lifting them up, obviously it is intact. Okay, so for the medial ankle, I'm just going to switch feet here on there. We're really looking for tibialis posterior, flexor digitorum, and flexor hallucis, as well as the neurovascular bundles on the medial ankle. So we usually use the phrase Tom, Dick, and a very nervous Harry. And so I'll show you where those structures are. You might need to use a little bit more gel around the medial and lateral malleolus because they're indent, and so this just might make it a little bit easier to identify those structures. So here, if you can see where my probe is, I'm just going to. This is the medial malleolus here, this bony landmark here. There, the first tendon is going to be the tibialis posterior, followed by flexor digitorum, and then a very nervous. And Harry's going to be, easy way to identify where Harry is you can just move the big toe. And so there's Harry right there, right in the middle of the screen. Depending on where you're at on the ankle, Harry might be right there. He is right underneath those neurovascular bundles right there. So easy way to find it, just move the big toe, and then right here is the tibial nerve right here. It has that honeycomb appearance. If you wanted to, you could follow again the tibial nerve down, as it'll have a branch for the calcaneus, and then becoming the plantar nerves as well. You can look at those structures as well. The other thing is you can move the probe up and watch these structures turn into muscles. Again, turn into tendons. You can follow them all the way up and down. As you move your probe down, further down into the ankle, you can start to identify some of the deltoid ligaments. They are going from tibia to calcaneus here and to talus here. So there's some of the fibers are right here. and right here. And so just keep in mind there's several of those that you can identify. You can even slide down and do the look for the spring ligament that underneath the talus, going from calcaneus to navicular bone, which is deep in here. As well, we can look for those structures as well. Now those I don't often scan, just because there's probably better imaging modalities to look for those, to look at those structures. And then, so last thing we're looking at after we've looked at the medial ankle, lateral ankle, and now we're going to look at posterior and the foot. So we're going to have our patients flip over onto their stomach. And from here, we're just going to image the Achilles tendon here. And so we're just going to take our probe and put it right directly on top of the calcaneus. And when we start doing that, you might need to, I'm going to get some more gel here, but as we're doing that, we're going to put it directly, and we want to make sure we image all the way down to the distal attachment of the Achilles, which is here. And so you might need to move your probe a little bit to get rid of some of the anisotropy as attachment. And then we're going to slide the probe up. If you're looking for like Achilles tears, they generally occur right at right here, right at the ankle joint itself. This is usually where they occur. But if you're looking for a tear, this is the flexor hallucis, deep to here. So just don't be, if you're looking for a tear, don't mistake this structure right here as something that's still intact. This is all the Achilles. So here we're going to take our probe from long axis and we'll move it to short axis, and we're going to go all the way from the distal calcaneus to where the Achilles comes off, and we want to look at the entire structure, because even like a tendinopathy or tear can be either medial or lateral or central. And as you move up, you're going to start seeing the soleus muscle fibers come off first here. So this is soleus, and as we slide up into the calf, we can start to see that's medial gastroc and lateral gastroc. Here, I'm going to change my depth here. So here you can see I'll come all the way back down again. So we go from Achilles, a little more depth now, so it looks a little different. Soleus is coming off here. Right there is still the Achilles for the gastroc, as this is all soleus. As we move up, medial gastroc here, soleus, and then lateral gastroc over here. So this is just a good image right here to get, where you can kind of see medial gastroc, lateral gastroc, and soleus, and all of those different structures. And you can slide all the way up into the calf. If you're looking for, just as we looked at long axis of the Achilles, you need to look at long axis attachment of the gastroc. So if we're looking for a medial gastroc tear, make sure you scan, here we have, the hair can take away the gel, so you might need more gel, but make sure you slide the probe all the way so you scan the entire medial gastroc. And so where we're looking for tears is we're looking for any disruption to this starry night appearance, and it usually fills up with fluid. Now the most important thing to scan here is not just short axis, but actually long axis. And we're looking here, this is soleus, deep underneath. This is the medial gastroc. These are the fibers, the penne structure. You can see my probe's a little bit turned, so I can see the fibers coming down to the aponeurosis, and you want to make sure you image these all the way down. Like this is where all the tears are occurring. right at the where it turns into ponderosa and connective tissue. So it's at that muscle tendinous junction. So you want to make sure you scan all the gastroc, slide both medial and lateral for that. And then do the same thing over on the lateral gastroc, move over there and do the same thing where you slide there as well. And look for all those. And this is what you're looking for. These, you want to see these nice fibular pattern, this muscle connective tissue in the muscle coming all the way down to the ponderosis as it's going to become the Achilles tendon. Extremely important to image those. For the proximal attachment, you can scan it now, but we're going to scan that in the knee region as well as other structure. You can also, if you want, you can look as far as the plantaris muscle as well. It's going to come off medially and move laterally. I like to actually start up in the lateral knee, and you can identify it usually pretty deep here. There's some plantaris fibers here, and then you can follow that as it'll go deep underneath as far as that goes. But again, big ones we want to make sure we find are the Achilles tendon in long and short, and then the gastroc muscles in long and short. Okay, the last thing we're going to scan here is the plantar fascia, and if we have our foot just kind of hanging off the table, it makes it pretty easy. You might need a little bit more gel, and you also might need to turn up the gain on your device, but we're going to take it and just put it over top of the calcaneus, and you can see it's very dark, and so I'm going to turn up the gain quite a bit, and we're looking for this is this is all just soft tissue here, the fat pad of the calcaneus, and then this right here is what we're looking at. And usually what we're going to do is measure that from top to bottom at its thickest portion, and so you can slide the probe both medial and lateral and try to look for the largest portion, which is going to be right off usually it's always off the medial calcaneal tubercle, and measure from top to bottom. And I think typically usually the cutoff is about 4 millimeters if you're looking for plantar fasciosis. But nice thing is we can actually see some of the connective tissue here. It's still pretty well organized that we can actually see in this scan actually. So looks good. Okay, so that completes the scan along for the foot and ankle region.